This is Dr. Pedro Ramirez, Editor-in-Chief of the International Journal of Gynecological Cancer. And today I have the great pleasure and honor to have back on the podcast for the International Journal Dr. David Gershenson from the University of Texas MD Anderson Cancer Center here in Houston, Texas, and Dr. Brian Slomovitz at Mount Sinai Medical Center in Miami, Florida. We're going to be talking about a recent publication in Journal of Clinical Oncology, a very important study. Phase 2 trial of ribociclib plus letrozole in women with recurrent low-grade serous carcinoma of the ovary, fallopian tube, or peritoneum, a GOG Partners trial, GOG 3026. Brian, David, thank you so much for accepting our invitation. Thank you for taking the time to discuss this really very important trial, and we're really looking forward to hearing from both of you. So thank you.
Great to be here, Pedro.
Yeah, Pedro, really, I'm always so grateful that you invite me to come to your broadcast. You're doing a phenomenal job. My only regret is that, and I know, and I've said this before, you're leaving, you're leaving in great hands, but you're leaving the role as editor. So thank you for all of you've done for me personally and for the field, and able to spread the news of such important research that's being done. So thank you for that.
Thank you so much for saying that, Brian. Really appreciate those words. So let's get into the to the trial discussion. And I'll start with you, Brian. For years, we have been treating low-grade serous ovarian cancer with chemotherapy, clearly not very effective at all, and then hormonal therapy with aromatase inhibitors. Was there a need to explore other options here?
Thank you for that. And truthfully, it's a great question, and it's a question we could talk about for hours. But in summary, we're learning low-grade serous ovarian cancer. It's a rare subtype of ovarian cancers. When we think of typical ovarian cancers, the most common cancer that women in their late 50s, early 60s get, it's high-grade serous ovarian cancer. Very responsive to chemotherapy, a very fast-growing, a distinct group of symptoms that we see. But we've learned over the years, and it's really humbling for me to be a part of this research, because really Dr. Gershenson has really defined this as a different entity. But low-grade serous ovarian cancer is more like, believe it or not, more like breast cancer, more like hormonal responsive breast cancer when it comes to treatment options, when it comes to response to therapy. And similar to that disease, it's not the chemotherapy that matters. It's hormonal-based therapy, and what we're learning really biomarker-driven type therapy. I know we'll expand a little bit more. Dr. Gershenson led the way with GOG 281, which is a drug called Mekinist, a MEK inhibitor. There's been other exciting new drugs. We got an FDA approval this year for low-grade serous ovarian cancer. And in this study, as we'll go into, there's something called a CDK4/6 inhibitor, which is another exciting avenue, and we'll talk about the results. But again, where did we get the idea from? From breast cancer and hormonal responsive breast cancer.
Excellent. So, great setup for the next question. I'll turn to you, David. Tell us about MEK inhibitors and how have they really entered the space of low-grade ovarian cancer?
Thanks, Pedro. Well, as Brian said, we had very few options, even up until about 2015. So we started to study MEK inhibitors. The first study was a phase 2 trial of selumetinib through the NRG Oncology, and the response rate with that MEK inhibitor was 15% in the recurrent setting. And then there were two second-generation studies, the Milo study, which compared binimetinib to standard of care chemotherapy. And that study crossed the fertility boundary and was a negative study, probably because the control group overperformed and because they had a better performance status and fewer lines of prior therapy. The first positive study was the GOG 281 log study, which compared trametinib to standard of care chemotherapy or letrozole or tamoxifen. And that study was positive in that the median progression-free survival with trametinib was 13 months versus 7.2 months with the standard of care. Response rate was 26% with trametinib. Duration of response was like 21 plus months, et cetera, et cetera. So that was the first study that really showed tremendous benefit. Both the Milo study and the GOG 281 study did show that patients who had a MAP kinase mutation, KRAS, but maybe even BRAF or NRAS, had a much higher response rate than patients who were wild type. And then most recently, there was FDA approval for the combination of avutometinib and defactinib in a phase 2 study, and now there's an ongoing phase 3 study. So we have many more options than we did even 10 years ago, and that's very important because these women live a long time. The prevalence is very high, so we need more options.
Great. So, and I'll stay with you, David. And with regards to the CDK4/6 targets, and what's the evidence prior to this particular study?
Well, as Brian alluded to, most of the evidence was in breast cancer, and we know that cyclin-dependent kinases inhibitors target these enzymes in the cell cycle that prevent the cancer cell, from going from G1 to the S phase. A number of breast cancer studies revealed a much higher median progression-free survival with the combination of endocrine therapy plus a CDK4/6 inhibitor versus endocrine therapy alone. There was also preceding this study, although not yet published, was a neoadjuvant study with abemaciclib, the CDK4/6 inhibitor abemaciclib plus fulvestrant in the neoadjuvant setting. And that had a 60% response rate compared to about 11% for chemotherapy. So those were kind of some of the studies that preceded this phase 2 study of ribociclib plus letrozole.
Excellent. So, Brian, turning to you, tell us about this study, the design, eligibility criteria, treatment arms, and the endpoints.
Yeah, no, it's interesting. On some of these rare tumors, the holy grail has always been to do a randomized phase 3 trial. And when we talked about, both myself and Dr. Gershenson just mentioned that we have an FDA approval, but prior to that, we haven't been able to do a really nice design leading to regulatory approval. So in the absence of that, we designed studies that look for efficacy. We look for, in order to get them to the patients in rare tumors like that, oftentimes we want to use drugs that are already FDA approved in order to, not get full regulatory approval, but more of repurposing into other disease sites. Really what we did is we did an open labeled, everyone got the drug, open labeled, single arm, phase 2 activity trial. We know, for those of you out there that don't know, phase 2 is really looking to see if a drug works in a certain type of tumor. So, open label, single arm, phase 2 trial with women who have measurable disease with recurrent low-grade serous ovarian cancer. The treatment was the CDK4/6 inhibitor and in a combination with letrozole. The CDK4/6, there's a lot of different proposed mechanisms, overlapping mechanisms, but one of the important roles that it has is to help overcome hormonal resistance. So here's the disease that many women respond to hormones, and those that don't, we gave the CDK4/6 to help overcome that resistance that they've had. Primary endpoints, overall response rate by RECIST criteria, looking at the measurable disease to see if it stayed stable, partial response, complete response, or obviously progressive disease, and typical secondary endpoints, clinical benefit rate, progression-free survival, overall survival, and importantly, looking at safety. Even though we knew the safety profile in breast cancer, we want to see if there are any new safety signals in the low-grade ovarian cancer population.
Excellent. So let's get to the results, and then, of course, obviously, we'll get into a lot more questions about that. So 74 patients screened, 51 enrolled, 49 treated. What are the highlights? What did you find?
Yeah, so really, in summary, the key highlight here is a response rate of 31%, 30.6%. We had one complete response. We had 14 partial responders. Amongst the responders, the duration of response was 21.2 months. So really a durable level of response in those that responded. Important component here is something called clinical benefit rate. We know in general, we want tumors to shrink. But in the absence of the tumor shrinking, we just don't want them to grow. And that's the clinical benefit rate, the stable disease plus the response rate, 84%. Median progression-free response, 14.5 months. Overall survival, 44.5 months. So really a nice high rate of clinical benefit rate, really the highest rate that we've seen in overall response rate in a biomarker in an all-taker population. One other interesting point that's not really written in the paper, when we presented this data 3 years ago, the response rate was 22%, and all the patients were accrued then. So without introducing any new patients to the trial, the response rate went from 20% to 30%, meaning that sometimes it takes a while for them to respond. And we've seen that stable, cycle 1, 2, 3, 4, 5, 6. And when you see the swimmer's plot, they may get a response after 6 or 7 cycles, which really highlights the need to come up with cytostatic therapies for tumors that are relatively indolent and growing, because we can get a response as we see over time, which again, to me, that was another key aspect of this. The responders could take a long time to respond.
Right. So we'll get into now some of the details, and I'll turn to David for this question from our fellows. The median duration of response was 21.2 months, while median progression-free survival was 14.5 months. Does it suggest a benefit concentrated in a subset of true responders? How could we identify responders?
Well, I think it does. And this is not an unusual trend in clinical trials. We see that the duration of response and effective treatments is generally longer than the median progression-free survival. And that was true, as Brian said, in this case. So I don't think that's surprising. It's interesting that the response rate in this trial, 30.6%, basically was double that of letrozole alone. There are 3 studies, 1 retrospective and 2 prospective trials, all of which showed a consistent response rate of 14% with letrozole alone, letrozole monotherapy. Here we've doubled it. We've also basically doubled the median progression-free survival. But I think the responders are special in that the duration of response was longer than the median for the whole group.
Okay. Brian, a question from Giuseppe Parisi and Gemelli in Rome. He's asking, this study met its primary endpoint in a single arm setting. If you had to define the minimum next step needed for this regimen to be practice changing, what would it be? A randomized trial with a clear comparator, a biomarker enriched cohort, or a pragmatic sequencing study? And why?
Yeah, no, it's really a real thought-provoking question, right? And what's the next step to go? So let me break it down in a couple of ways. Number one, and I'll talk about the specific type of trial, but our next step is to move this to the first line. Okay, right? We just completed, and Dr. Gershenson helped mentor this recent trial that was reported a couple of weeks back at the SGO, demonstrating that hormonal therapy by itself in the first line is not better. It's an inferiority trial. It's not even just as good as chemotherapy and hormones. So the current first line therapy is still chemotherapy and hormonal therapy. Now in the second line, we have a 31% response rate. We have a long duration of response. It's not on the NCCN guidelines yet, which is a committee review of positive studies, but I would suspect that it may get on NCCN guidelines, and that in itself will help get the drug into people's hands, which is important, meaning patients, throughout the US with NCCN guidelines, most insurance companies recognize that, particularly in a prospective trial with a response rate like this. So to do a randomized trial with a clear competitor, I think that, the as I learned in fellowship, the enemy of good is perfect, but I would do that more in a frontline setting because I think that's where we're going to make the next change. We're going to get this into our patients' hands, but the next change will be if we can move it into the front line.
Okay.
The avutametinib defactinib, Dr. Gershenson alluded to, it has a high response rate in biomarker positive patients, KRAS mutated patients. Maybe a step here will be just to focus on the biomarker negative patients in order to, because that's a good response rate. Let them run with that. In the second line, our biomarker negative patients, where the response rate for that combination is only 17%, maybe focus on this component here, and then and see where that takes us. I think pragmatic sequencing trials, maybe that'll be inherent in this type of pathway. But first we need to get it into people's hands to use. We need to further evaluate it and to do the right trial in the first line. I think will be the next step, great step in helping this affect the standard of care moving forward.
Okay. David, turning to you, Nicole Chris from Australia, she's asking, in GOG 281, letrozole monotherapy had a stable disease rate of 70% with an overall response rate of 14%. While dual therapy in this study with ribociclib may have a overall response rate of 30%, it has an almost identical clinical benefit rate of 84% to historic monotherapy. What encourages you that dual therapy enhances endocrine efficacy in low-grade tumors?
Thanks, Pedro. Well, actually, in GOG 281, the response rate to trametinib was actually 26%, not 14%. Here we have a 31% response rate with ribociclib letrozole. I mean, I think they're both good therapies. I would not put too, it's nice to look at clinical benefit rate, which includes obviously stable disease patients as well as responders. But, stable disease is a little bit of a waffling kind of an endpoint, because how long do you have to have stable disease to call it the best outcome in a trial? A lot of trials will say it needs to be at least for 12 weeks, but some don't even define it. So clinical benefit rate to me is not that great an endpoint. Response and median progression-free survival are much better. But I think the bottom line is again, we're expanding the number of treatments we have. MEK inhibitors are great. This is CDK4/6 inhibitors with endocrine therapy are really can be effective. So I think they both have a role in the treatment of recurrent low-grade serous carcinoma.
Okay. This next question is pertaining to the point of cohort. This cohort has CDK4/6 that is comparable response as the MEK inhibition. How can we apply and evaluate the treatment response to CDK4/6 inhibition combinations in the frontline setting rather than this single arm comparison?
Well, I think as Brian also mentioned, moving forward, the NRG GY019 trial is now complete. We have the findings that chemotherapy letrozole is probably somewhat more effective than letrozole monotherapy based on a non-inferiority design. So I think what we're going to see moving forward is we're going to see CDK4/6 inhibitors and endocrine therapy can continue to be studied in the recurrent setting, but it's also going to move up into the frontline setting in combination with letrozole. So I think, if you were going to design a trial, it might be a MEK inhibitor or MEK inhibitor combination versus endocrine therapy CDK4/6 inhibitor versus the current standard, which is chemotherapy followed by letrozole, if you had enough patients to fulfill a 3-arm randomized phase 3 study.
Okay. Brian, this question from Vincenzo Tarantino in Policlinico Gemelli says, you screened 74 patients, but you ultimately treated only 49. Which eligibility criteria most commonly limited trial entry, and how might these constraints have selected for a filter or more indolent population, potentially impacting the generalizability of the observed efficacy?
Yeah, no, this is really, again, thought-provoking, great question. One of the things is, based on the really the great work again from Dave Gershenson and his group, they did previous work showing that letrozole maintenance therapy in those patients who were treated helped keep the disease away longer. And again, that was the experimental arm of the first line trial. When we wrote this trial, it was really prior to the widespread use of that. And we eliminated or excluded those patients who had prior letrozole use, unless it was used years ago to treat breast cancer. So as the study went on, we realized a lot of the patients were screened, and then on a deeper dive, they already had the letrozole, which excluded them from this trial. So I wouldn't look too much, truthfully, into the 74 to 49 from the screen to the with the screen fails. What this will help us with, however, in moving forward, I think in the second line setting, we need to come up with some data, and it may be retrospective real world data of changing the hormonal backbone, because a lot of those patients will get it in the front line, and then maybe adding a fulvestrant, or maybe even a different mechanism, AI and exemestane or something like that. So I don't think. I understand reading it, you scratch your head, why was that there? But I think it was more toward the science progressed, a lot more use of letrozole in the first line, and that would exclude a lot of those patients. I don't know, Dr. Gershenson, is there any other um, reason that you could see that these were excluded, the higher rate?
No, I think your explanation's right on.
Okay. David, turning to you from Giuseppe Parisi and Gemelli, he says your eligibility criteria allowed for prior endocrine therapy only if it was discontinued more than 6 months earlier and without progression on that therapy. How much do you think this criteria enriches the endocrine sensitive biology, and how should clinicians in the real world see this and translate this?
Well, there are a few implications. Number one, we were careful not to include eligibility for patients who had actually developed disease progression on letrozole. So a lot of these patients had received letrozole for breast cancer, but never had a disease progression there. And we did not, we excluded patients who had low-grade serous carcinoma who progressed on endocrine therapy alone. Now, was that the right thing to do? When you look at the breast cancer experience, there are instances of patients who fail endocrine therapy alone, and then they're just continued on the same uh, aromatase inhibitor with the addition of a CDK4/6 inhibitor. What does that look like? Although I think even in the breast cancer literature, most of the time, if a patient fails frontline endocrine therapy, they will go to a different anti-estrogen such as fulvestrant plus a CDK4/6 inhibitor. But it would be interesting, and I don't think we certainly don't have the data in low-grade serous carcinoma, is what would it look like if you just took patients who progressed on, let's say, letrozole and kept the letrozole going with the addition of a CDK4/6 inhibitor. I don't know. I don't think the response rate would be that terrific after conversion, but that's something that's I think right now is an open question.
Great. And Dave, I'll continue with you. This question from Lucia Ribeiro. And she's asking, looking ahead, how do you envision hormone receptor status and molecular stratification evolving to guide treatment stratification in future low-grade ovarian cancer trials?
Well, I don't think we can use estrogen receptor as a stratification factor because the problem there is 95% of these patients have a positive estrogen receptor. Now, there's a lot of discussion about how do you measure the estrogen receptor, but we don't really have a great way right now of quantitating that. So I don't think it's going to end up being a stratification factor, to my knowledge, in the future. Certainly, progesterone receptor could be. Residual disease certainly was one. MAP kinase mutations, all the known prognostic factors, stage, age at diagnosis. Um, but I don't think we're still trying to learn more about the estrogen receptor and can we individualize treatment recommendations based on that. And right now, I think we're at a loss.
Great. Brian, turning to you on the topic of side effects. Leila Bulazzi from Georgia is asking, were there any differences in side effects or dose adjustments between older patients and younger patients?
Yeah, no, it's a good question. Truthfully, there's the most important part, there were no new safety signals that we saw with this well-known complication. Um, two we saw in other diseases. So, we had very, very few high-grade events. only 4% of the patients had treatment discontinuation, no dose limiting toxicity. So with such a really a safe profile, it's tough to compare one group to the other. They both did well.
Okay. David, turn to you. Alvin Matthew here from Houston Methodist. He's asking, when selecting patients for ribociclib letrozole regimen, do you believe biological markers such as H score for ER expression or P16 loss are more predictive of success than clinical factors like prior lines of therapy or disease burden?
That's a great question. We're not there yet, but let me give you a little bit of information. So, from Mark Carey's group in Vancouver, they found in preclinical studies, and there's also some evidence in clinical trials that patients whose tumors have P16 loss have uh, a, a better probability of response to CDK4/6 inhibitors. Mark's group also found that these patients who did, at least the tumors that responded better, tended not to have a MAP kinase mutation, KRAS, BRAF, or NRAS. So I think we're starting to learn more about how to work to factor biomarkers into our decision making. Just to let you know, we are with Brian and KK Wong from our group. We are in the process of completing analysis of a translational research study related to a GOG 3026. We're looking at whole exome sequencing. We're looking at P53, P16 rather, and we're also RB, phospho-RB may also be a marker. So I think stay tuned. We will, I think, learn more about this and how to triage patients better.
Excellent. So another interesting question from Naya Seminario from Spain, and this is for you, Brian. She's asking, the trial highlights a markedly better safety profile with ribociclib letrozole compared to historical MEK inhibitor data, with only 4% discontinuation rate due to adverse event. Given this high tolerability, should this regimen be prioritized for patients where obviously quality of life is the primary clinical objective, even if they harbor mutations like KRAS that might traditionally favor MEK inhibitors?
Yeah, no, it's a good, again, it's a good question. I think this all comes down to the pre-treatment conversation that we have with our patients. Just like what, a lot of times people think oral therapies are easy without side effects. This one's relatively straightforward. Other oral therapies aren't as straightforward. So I think when we're discussing with our patients which direction we're going to go in, we have to weigh the risks and the benefits, talk to them about the side effect profile, and there's always alternatives to care. So would I say flat out better quality of life, less side effects, go with this in the in the mutated KRAS patients? Definitely not. Would I say if there's a patient who's very concerned about a side effect profile, who's willing to give up a couple of cross-trial comparison percentage points in response rates, it's something to consider. The issue is with the sequencing. Sometimes patients say, well, let me try this first. Then they could always go to a MEK-FAK inhibitor, particularly after the CDK4/6 inhibitions, or vice versa. So, it's part of a longer conversation about what the risk benefits of a certain treatment.
Excellent. So we just have a couple more questions, and I'll turn to you, David, for this one. Beate Sarta from Latvia. She's asking, in a real-world setting where many patients receive frontline letrozole, how should we sequence these therapies? Does progression on an aromatase inhibitor alone imply resistance to the dual signaling blockade of ribociclib letrozole, or can the addition of a CDK4/6 inhibitor effectively resensitize these tumors?
Yeah, another great question and sort of related to what I had said before. So we pretty much know that if a woman with low-grade serous carcinoma progresses on letrozole or anastrozole, retreating them just doesn't seem to be worthwhile. And that's also true in the breast cancer literature. Now, there's one possible exception in that another aromatase inhibitor, exemestane, may still be effective in women who progress on anastrozole or letrozole. So that's something we need more information about as well. But this gets to the point I mentioned a little earlier. If somebody progresses on letrozole, can you just keep them on letrozole and add a CDK4/6 inhibitor? And again, I don't think we have good information yet about that, but I think we will over time accumulate information. I don't know that we'll see any clinical trials that will use that as a design, but we will eventually learn more about that.
Great. And as a last question, of course, as is tradition now for our podcast, this last question is from the AI interpretation of your study. And I'll turn to Brian for this last question. The question is, without a randomized comparator, how confident should we be that the 30.6% response rate and the 14.5-month progression-free survival truly represents superiority over endocrine monotherapy or MEK inhibition rather than a favorable patient selection or cross-trial optimism?
No, great question. So before I answer, Dr. Gershenson, when they say AI, they're referring to artificial intelligence, not aromatase inhibitor. I know you're still reading a paper newspaper, so I don't want to give an answer that you're not used to.
Yeah.
Listen, it's a very, very good question. It's a spot on question. Ideally, a randomized phase 3 trial is a way to go in this situation. It's a rare tumor. We actually accrued ahead of schedule, which is, which is very nice and rare in today's day and age in clinical research. We accrued ahead of schedule, but to make it a head-to-head trial would have been very, very difficult. I understand there's limitations with single-arm trials, cross-trial comparisons, maybe a little healthier population in clinical research than it is in the real-world setting. But we have to take the best data out there and incorporate that into our current clinical care to the best of our ability. It's not worse than what we have. It's not. It's good numbers to start with. And I think just like any phase 2 like this, that data that we get out there that we can use in clinical practice, I'd encourage practitioners to use it, see how it works in their patients, and see if their responses are aligned with what's been reported or not. But I think, truthfully, I've been able to use it on protocol and off protocol. I'm seeing good responses. We're never going to be satisfied till we get 100% response rate for this disease. We need to do better. I want to give a quick shout out to Dr. Gershenson's group and Lauren Cobb, who did a neoadjuvant trial with a similar combination with great responses. So the studying hasn't stopped. The research hasn't stopped. We're looking for different areas. But I won't insult AI. I'll say it was a great question, and there are limitations, but I don't think it should limit our use.
Excellent. Thank you so much to you both. Fantastic podcast. Once again, always love hearing your opinions, your discussions. Thank you for all that you have done for the study of low-grade ovarian cancer. So many patients continue to benefit from all of this research and on the partnership that you have created. Congratulations again, of course, obviously to GOG partners as well for supporting these trials. And to you both again for accepting our invitation to speak with us at the International Journal.
And Pedro, let me just quickly add to what Brian said. It's really been a pleasure sharing a number of these podcasts with you, your leadership. And I think you've done a phenomenal job with the journal. I know you're going to be stepping down soon, but I've been very impressed with your leadership and your mentorship with all of these young GYN oncologists and other healthcare professionals, the way you have really educated them. So thank you.
Thank you so much.
And Pedro, if it's okay, just a moment. You mentioned GOG partners towards the end. This study was initially sponsored by one of Dr. Gershenson's good friends, Larry Copeland, when he was the president of the organization. Tom Herzog then took over the presidency. These are sponsored trials by our organization. We got some money, truthfully, from the pharmaceutical companies, but we couldn't do these without our cooperative group. And I know both you and Dr. Gershenson are strong supporters of our cooperative group, and we're really focusing on changing the standard of care, not only for this disease, but for many that we treat. So, I do want to shout out. I should have done it earlier. I want to shout out to the GOG leadership for allowing us to do this investigator-initiated trial.
Well, thank you both very, very much. I'm honored.